This is amazing. Wow.
Happy
Thank
to take
you.
questions. Sure.
Great.
My
Great.
pleasure.
It gave me really goosebumps remembering my early days as setting up my own lab. I learned PV loops from you and see
They're
how
still-
that.
They're
Yeah.
still useful.
Yes, and I still see that how you focus on the clinical questions and provide so much more insight beyond the mechanism, but also therapy. And of course, you know, the branch amino acid is something very close to us as well. And seeing that it's actually being implicated, I remember in our lab meetings, we were very excited to see this. So maybe we can open up to questions to our panelists and also to our audience. And I can see Gabriel is actually opening up, and so ready to go, Gabriel?
Yeah. Well, thank you so much, David. This was outstanding as usual, really, from clinical to the basic mechanism and backwards. So also, particularly in the spirit of the journal, you know, the seminar hosting now, which is a journal of cardiovascular aging. So can you elaborate a little bit more about what is, in your opinion, the role of aging in FPF pathophysiology? Because, you know, it's known that, I mean, it's been associated that FPF is more prevalent in older subjects compared to milder, although as you might refer, this is perhaps not the modern FPF that we are seeing now with the increase in obesity, and we know that your cohort of Hopkins is fairly younger compared to the others. So what do you think will be the aging component? So where the old FPF patients are in the calcium tension curve that you have shown now?
Well, so we've looked, you know, each time we do these kinds of analyses, whether it's omics or it's like cellular physiology, to the extent that we can, we look and see, you know, what is there an age effect? I mean, in order to do that, you really do have to have the larger numbers. So for the cell studies, we're very happy to get data in, let's say, 15 to 20 patients. That's too small a group to make any kind of meaningful subgroups. I think the main comment that you've made, though, already is the one I would want people to think about. Yes, when I started my career and when I first got interested in this in the late 80s and 90s, doing pressure volume loop studies in humans and realizing that what we were thinking couldn't be right because they didn't have what was in my textbooks. But I was looking at it and I knew something was wrong. I didn't know what, and I didn't know how long it would take me to figure anything out, but I knew something was wrong. They were older. They were typically older. But obesity is affecting kids. It's affecting teenagers everywhere. And the planet is not only getting heavier because of people, but the age at which this is taking place is happening earlier and earlier. I also think that it used to be much older women, and more predominantly female. The sex disparity is also declining. I think we're seeing more and more getting close to 50-50. And part of that may indeed be men even earlier tend to put fat in their stomach, and it's a visceral fat. They're the ones who are probably more likely early, premenopausal women put it more subcutaneously. It's different properties or less pro-inflammatory kinds of fat. So in that sense, men now become more at risk actually for developing this, both earlier because obesity has become the dominant comorbidity, and because they're men, because they've lacked the estrogen component, which I think helps sort of fat catabolism and distribution. Estrogen itself is kind of PPAR alpha-like effects. So in that sense, I think it's all changing. No offense to the journal and the idea that it's interested in aging. I'm not saying age doesn't help you. I suspect, you know, the older you get, the more you accumulate everything else too. But it's just, it's changing a lot.
Great, thank you. Dr. Takamian?
Is it me? Heinrich?
Yes.
Or?
Yes.
Yeah, wonderful.
Yeah,
thank you, David, very much. That was a whirlwind and wonderful. It reflects really the complexity of metabolism. And I think all of us spectators have their special actors And
Right.
you've been focusing on a number of actors, and other people focusing on a different set of actors. I'd be interested, David, in your opinion, but two things. First of all, the concept of metabolic reserve of the heart. And that is a phenomenon that applies to the normal heart and a diseased heart, and what are the main features of the metabolic, just as there is a contractile reserve, what fuels and supports the metabolic reserve. And the second question is, well, what do you think of my pet hypothesis, unloading the heart from especially the HFpEF heart from metabolic stress? And we're all familiar with hemodynamic stress, we're all familiar with neurohumoral stress, and pay relatively little attention to the metabolic stress, which can be modified, as we're witnessing, day in and day out, and bariatric surgery, but also, the SGLT2 inhibitors, and who knows, even metformin, and unique properties of metformin, linking substrate oxidation to a greater intent than other hormones to substrate uptake. And then Gerald Reben's hypothesis, Lou Landsberg, and Jim Young of the catecholamines in obesity. So I'm stopping now, and
Well, you've laid out, I think, the future of what my lab and others is now going to be trying to address for the next, not quite decade, or we'll see how long I go. But I agree with you 100%. I mean, one of the things that kind of stunned me about our metabolomic signature, which is it's far from complete, and we're now filling in a bunch of other pieces to get a fuller picture, is just how fuel inflexible the HFpEF heart would seem to be. If we thought the HFrEF heart was fuel inflexible and lost some of its ability to utilize anaplerotic sources to compensate for other problems, add diabetes, add the inability to basically get sugar in, and simultaneously take the heart failure part of lipid catabolic processes and depress those, not use branched chain amino acids either, you're left with probably lactate. And actually, I think amino acids, the one thing that seemed to be up the most in our heart muscle biopsies were a bunch of amino acids. And I haven't, again, this is all in the paper, and I have time to go through all of the other components, but there's a story there. And we're beginning to look at a lot of other components of what you refer to as the of metabolic stress. Exactly, I like that term. What are the transcription? What specifically do you need for appropriate transcription of oxidative phosphorylation genes and an enhancement of the ability to generate ATP? Because they don't look normal actually in HFpEF. I didn't go into that either, but some of that's in the transcriptomic paper. You just have to dig through. But we're finding this, and why is it abnormal? And what would control, both transcription and translation in particular? We're looking at that. There are some other interesting things that are going on the acetylation side, and because of abnormalities of Krebs cycle intermediates that we report. So we're looking at what that might be doing. Obviously, that has nuclear implications, which then turn into transcriptional signatures that are contributing to this sort of metabolic stress. And fixing that is, I think, exactly what needs to happen. The only things I think we tried, more in HFrEF than PEF, if I recall, is we tried to block fatty acid oxidation. I think we used a drug that And when looking at our own data, I wouldn't have guessed that that would be the best thing to do, actually. I mean, I don't know what you feel, but to me, it looks like the heart's doing it already. And I don't know why that's necessarily going to help. And it's not as if blocking that is somehow magically going to fix diabetes and fix insulin, desensitization. So all you're doing is adding kind of a little bit of a fuel and flexibility drug on top of a pre-existing fuel and flexibility. We need to be cleverer than that, I think. And the good news is we haven't tried a lot of the things I'm thinking of now. And I'm sure you thought of these all too.
David, I could not agree with you more. And since I'm probably the oldest one on this panel, I'll tell you, years ago, people thought metabolism, everything is known and nothing further needs to be known. The opposite is true. The horizon is infinite, really.
I agree. I agree. My comment to the world is that, and you'll like this, is that as a math-oriented hemodynamics person, I looked at some of these metabolic charts, which look way worse than any Intel computer chip diagram. And I just got scared away from it. And it's taken me 40 years. And now suddenly I have to do it because it's important, and it's obviously important. And as you say, we know actually remarkably little. Maybe the Intel chip analogy in that sense is true. It's quite complicated, but it's incredibly important to get right.
Yes. So Dr. Kass, I have to move on, and because there's quite a few questions from the audience,
I see, there are 9.
From the chat. How about I read very quickly and then you answer in a very short translations. Okay. So the first is about the hormone therapy, hormone replacement therapy. Do you see that in a woman subclass, when they have better survival, are they actually correlated with the hormones replacement therapy status?
There were only, so the short answer is I don't actually absolutely know the answer to that, although we would know if they were on it or not. Most of these people, they're all postmenopausal, that's for sure. There were only, I think, 10 in that subgroup, and it would be hard to imagine we're statistically powered to, even if we knew what it was, no matter what the distribution was, to really figure out whether that is helpful or not. I've been certainly I'm sensitized to the fact that estrogen, whether given as a hormone replacement or your body before you're menopausal, definitely has many important manifestations that could interact the things that we're looking at. So it is potentially relevant. I don't know that would explain, though, the NT-proBNP median being over 1,500 in the one group with the highest mortality, and literally 50 or 40 something, in that subgroup. I don't think that's going to be just estrogen replacement.
It's actually quite difficult to generate this causal relationship, it's correlation right now.
Yeah.
So the second question is actually the sarcomere data that you clearly see differences between the HAPF, from the obese conditions. Actually, you see quite similar patterns of sarcomere function between the HAPF and the HAFrEF. And yet the HAFrEF targeted therapy to improve sarcomere structure or organ function actually failed in the HAPF trials. Why?
You just put some words in there.
I saw that's
the
what
therapy he's talking about are just anti-HFrEF drugs, and the point there would be we actually don't have a successful sarcomere enhancing HFrEF. The FDA just declined approval of omecamtiv, which was the closest we've ever gotten. And the drugs that we have been using have been all neurohormone blockers, like angiotensin receptor blockers and ACE inhibitors. And that's really not the primary problem with this syndrome. It just isn't. And we've, if anything, what I think is remarkable, and hopefully our data at least makes people think twice, is that for decades, we used pretty potent calcium channel blockers and beta blockers in these patients, and they are not known to increase contractility. In fact, I can guarantee that the doses we were giving, they were decreasing it, and we were often using it because they had hypertension and hypertrophy. Now that they're more obese, I would question those drugs very strongly. So I think we just have to rethink things.
No, I agree. Actually, I see there's an effect of the gastric bypass.
Bypass. It's been looked at in small trials. We have yet to get a very large trial together. It's complicated because the surgeons generally don't like to see, a patient they're taking to the OR for something like that with a diagnosis of being hospitalized for heart failure, several times. And so it's been avoided. Now that we have almost gastric bypass-like effects from the new drugs going at appetite, I think that's where we're going to learn this in a large enough sample size to figure it out.
The question from Marinja is the status of inflammation in HFpEF. I'm also sharing that question from your transcriptome studies. You don't seem to actually identify inflammation as one of your major, at least from the PCA components, the key pathways affecting the HFpEF.
I think it's there. I will say that the question of how much of it is really in the heart, and remember, most of the transcriptomic data I showed you is myocardium. I think it's not that much. I mean, we don't see it in the biopsies of these patients. We that it's all been evaluated by our transplant pathologist. It certainly doesn't look like typical myocarditis or much inflammation. And so, but that said, I think it's very important. I think macrophages are really important. We are looking at these things. I just don't think that it's going to be all in the heart. I see from Peter. I can see the questions in front of me too. You can. Great. So, what could be the driver for systolic dysfunction in HFpEF? That's the bazillion-dollar question, Peter. I can tell you that we are looking at this structurally. I showed some X-ray diffraction data for REF. It'll be coming, I think, hopefully by the fall. But we've already got some preliminary data. I can just say that there definitely is something going on structurally that appears only in the obese subgroup, which is quite interesting. So, and we've got EM that actually shows some very striking differences, whether you're very obese or not. So structurally, I think it's good. There's going to be something going on. And then we've been looking at PTMs, and we've got some phosphorylation data. We just don't have it pinpointed yet as to exactly what was dephosphorylated or phosphorylated. That's work in progress. We're struggling with our proteomics in such tiny pieces. It's been hard to get good phosphoproteomics from 3 milligram pieces. There are also HFpEF patients who have small size frail old ladies without much obesity. What do we think about? I think that's kind of the old HFpEF, right? And we used to be, we called them at Hopkins LOL before that was laugh out loud. It was little old lady. It was little old lady hearts who had, small, and I get in Asia, in parts of Asia, this is still a more common phenotype, although obesity is increasing there too. And it has probably a somewhat more hemodynamic oriented component. But that being said, I didn't mention this, but the metabolic signature that we've published and I showed actually doesn't segregate by BMI. I thought it would. I was stunned that it didn't. Helmut probably would say, yeah, of course, that's what I expected, but it did not. And so in that sense, we tried things that should have worked in the little old ladies. We can treat blood pressure. We have drugs to treat hypertension and hypertrophy, and they weren't getting better. So I think metabolically, it's probably also different. And I think we kind of missed it, but it is a different phenotype. Maybe the last question, do you think glucose oxidation beneficial during cardio? Yeah, I mean, this gets to I think what Helmut was saying, that's one of the classic reserve mechanisms that you tend to switch over and use more glucose when you have to do something quickly, and where your ATP, your oxygen requirements are definitely less. You don't get as much ATP, but your oxygen requirements are less. I just don't know how that's going to work with someone with a BMI of 50 and striking insulin desensitization. It's not. I think that's where the weight loss therapeutics may turn out to be absolutely critical to get past some of that bottleneck so that fuel reserve with glucose can be used again.
Maybe David, you can give a last shot at Laura's question.
Yeah.
I want the answer too.
Male name, high-fat diet, mouse models fit with human data.
That's from Gabriel.
Right. Well, with all due respect to Gab, sometimes they do and sometimes they don't. So with respect to the sarcomere, they don't, at least so far. We're tweaking it a little bit. We have an idea we're going to play around with to see if we can figure that out. There's, with respect to something I haven't talked about or shown any data on at all, but turns out we've been looking at histone, PTMs, and sort of associated transcriptomics. His model looks amazingly good compared to human, and much better, for example, than the ZSF1 rat, which is another popular model, or one of the pig models. On the other hand, we're also looking at a lot of different metabolic pathways, specific metabolic pathways. And if I brought the postdoc in who's working on that and he would answer your question right now, he'd say, yeah, not so much. There are things that it definitely does. I think their ER stress finding and the signaling was very much a part of human HFpEF. That was a big, that was a big focus of the original paper. And that also gets to abnormalities of processing, protein processing and quality control. I think those are real. But yeah, it's complicated, and it's not really that surprising. I mean, human beings, I don't know any disease of human beings that basically is a mouse on LNAT. It did a bunch of things that are interesting. It was, it's tractable for sure, more than some of the other things people have been doing. It's being used all over the place. It's probably the most prominent model ever. I'm a little concerned that it's being used a little bit too glibly, I suppose. I would like to see more people look at our transcriptome now that it's published, and look at our metabolome now that it's the proteome's coming in human, and then start to ask whether the things they're interested in looking at are in that model or not. It's not just all about EE prime and hypertrophy and, do they have something that looks like, and they have a normal ejection fraction. We've been phenotyping our animals kind of the way we were phenotyping humans 30 years ago. And we need to start using kind of the signatures that are now becoming more cellular molecular as they're being developed from human to better pick the model and sort of fit at least the model to our question. No model is going to have it all. I will say that, I will guarantee that. I'd be shocked if we ever come up with a model that simply has it all. So that's a very important question.
Very
All right.
good.
I second that. I just want to paraphrase it. Statistical.
One more thought, David. I think one pervasive thought that you brought out in your lecture so beautifully is that the heart selects the most efficient fuels for a given environment. And this is adaptation. And then once this adaptation breaks down, becomes maladaptation, the consequences appear to be endless in general and very broad general terms.
Yeah.
Absolutely, I agree.
This is the one organ that not only needs more ATP than any other, it has to do it your entire life, and it has to be able to keep doing it. And the only way it's evolved to be able to do that, I think, is to be metabolically, multidextrous. And you keep chopping off various roots that, and yeah, it's a real driver.
And the chase, as far as I can see, will not end that soon.
No. Yeah.
Well, talking about fuel utilization, I think David, you just provide a lot of fuels to our continuing quest for the complexity of the disease mechanism as well as potential therapies. And thank you so much. And I probably leave this to Dr. Maria to have the final concluding remarks.
Thank you. Gabriel, did you have a question? Did I interrupt you? I'm sorry. You okay?
No, it's fine. It's fine. Please, we are already able to.
Yeah. All right. Wonderful. David, thank you so much for fabulous. And it's wonderful to see you are so excited and passionate about this. Wonderful, beautiful presentation.
Yeah.
Grateful to Dr. Hagmeyer and Dr. Gabrielle Chiazzarella and Professor Yibin Wang, as usual, an old friend from Baylor days. Grateful to you all. Dr. Dr. Gerha, who is my next door. And again, I'm grateful to you all. It's a fantastic presentation. Grateful to you all. Thank you, David.
Thank you. Thank you. Thank you, guys.
Thank you all. Bye-bye.
Best wishes. Bye-bye.
Bye, everyone. Thank you.